Okay, so welcome. Children, today, now this is the follow-up lecture of heart disease. Hopefully it's not too difficult for you all. So what you all have to understand is that you need to have a very general idea of how to manage heart disease, and then will be only a very few specifics asked from you all, right? So you just need to know the general basics, and that's all you need to know when you are doing your MBBS. Okay. So, but you need to have a clear understanding as to the different kinds of heart disease that you can encounter, and also the general knowledge that you have needs to be applied to this condition, because you get this general knowledge from medicine, right? And maybe from pediatrics, so about heart disease, and therefore that needs to be applied to an obstetric patient as well, right? So today, because I went through all the general sort of characteristics of this disease and what we do about them last time, today we will try and concentrate on two diseases, and then the next lesson we will concentrate on two. Today we are going to look at aortic valvular disease, right, and mitral valve disease. Those are the only two things that we are going to concentrate on. And I'm not going to give you a lecture on these diseases. What I'm going to do is to try and tell you how we manage this across the obstetric cycle, right? What we do actually when we meet them in our clinics. So initially, let's look at aortic problems, aortic valvular problems. Now, as you all understand, right, the left side of the heart, we have two important valves that we have problems with. One is there's a valve that makes or allows blood flow from the left atrium to the left ventricle, okay, and that is the mitral valve, okay. And then the left side of the heart pumps blood out to the aorta, and there's a valve there which is called the aortic valve, and it has three cusps there, which is called a tricuspid valve, right? So any problem in these, right, these are the two problems. We have patients who come in with this. So if you are going to concentrate on the aortic valves, majority what we are looking for, basically what you all have to know are two things, that is aortic stenosis, right, valvular stenosis, and aortic regurgitation, right? Those are the two things. Of course, there may be other things like congenital, different kinds of congenital variations, malformations, all those things, which are left for people who are doing or looking after the cardiac patients, right? For us at MBBS level, right? Please remember these are the two main things that you need to know about when you are discussing these patients, okay? Right. So let's say now, first of all, let's look at the preconception clinic, because we are going to go through, as you all understand, I teach you all to go through an obstetric patient by the obstetric cycle, which remember was coined, and this whole method of teaching was invented by Mr. Dr. Dilip Viswanathan, who is my teacher in UK, and then he will also be coming to Sri Lanka in November. So hopefully some of I'm trying to get you all to meet him, right? And that is he invented the way that these are taught, right? So remember, it's preconceptional, first trimester, second trimester, third trimester, and then delivery, and then postpartum care, and then going on to the preconceptional care. So that is how we look at the disease, okay? So let's look at the aortic problems. Now, when a patient comes in, remember, what are the problems? When you are looking at the preconception clinic, you need to counsel them initially. Okay, look, these are the problems that you have. Okay. So if you look at counseling, there are two large areas in which you need to think about counseling. First, counseling is the general problems, or we counsel them. Every pregnant patient, there are certain principles, general principles, which we need to counsel them on, which I'm not going to touch today. And there are specific things, right? Specific problems we address when a patient is having specific problems. These are the ones we need to talk about, right? So if a patient comes in with aortic disease, usually they are already diagnosed, they will have a diagnosis card, they will have a diagnosis, and most probably they'll be followed up at a cardiology clinic, right? And they will come to you, doctor, look, I have this problem and I want to get pregnant. So these are the things that needs to be assessed. Of course, remember, as obstetricians in a preconception clinic, we definitely do not manage these patients alone, right? So we have to have what is called a multidisciplinary team involvement, or a MDT involvement. That is number one. So the cardiologist will need to be involved in the management in every step of the way, because the cardiac disease is assessed, recorded, managed, and if complications occur, it is a cardiologist who will manage. And the obstetrician comes in either for a termination of pregnancy or a delivery, and the cardiologist will direct us to tell, look, now it's dangerous, please deliver this baby, right? Even the drugs are initiated, started, and monitored by the cardiologist. So they get a multidisciplinary input. So the obstetrician comes into play to look after the baby, and basically the cardiologist will look after the mother, right? And if delivery is required, the discussion will take place and the obstetricians will initiate the delivery. You all understand? Right. So it is always multidisciplinary team involved. So in the preconceptional period where they come in initially, the conversation is going to be started along with the cardiologist about this patient. Is that clear, children? Right. Now, let's look at aortic stenosis, right? Aortic. So what is the problem when the aorta or aortic valve stenosis? The problem is what? The heart, or left side of the heart or the ventricle cannot push out the blood, right, to the system. So therefore, eventually, if aortic stenosis increases, eventually what happens is the patient will go into heart failure. Okay. So now having heart failure during pregnancy is a big problem. Now, what we have to understand is, initially, when the patient comes in, the patient needs to be assessed and the cardiologist will assess the patient. What are the two main things you have to remember when you are asked about assessment, children? We have to know the New York Heart Association classification, which I discussed in the first lecture, right? The functional classes. But for pregnancy, remember, for pregnancy specific problems, when a patient with heart disease comes to you, there is something called a modified World Health Organization classification, right? Which you need to run. I will put it on the, I think I had a picture, right? I will put it on the Telegram group. Just look at it. It's slightly different, but it is specific for patients having, pregnant women having heart disease, okay? So these are the two main classifications which we use to classify the problem, right? So remember, New York Heart Association classification and the modified World Health Organization classification for heart disease functional status 1 to 4, right? Those are the two classifications to use. And with that, remember last time I told you how these patients are assessed, but the main thing, children, is shortness of breath or dyspnea, right? And along with that, different things like arrhythmias, all these are assessed. Plus, that is the clinical assessment. Then, of course, you have the instrumental assessment. What are these? These patients will be assessed with ECG, yeah, echocardiograms, stress testers, right? Different ways of doing stress ECGs, right? Different kinds of echocardiograms can be used, right? Then different things can be measured, like antrinatriuretic peptides can be measured in cardiology, right? Pulmonary arterial pressures can be measured. So all different types of pressure systems, pulmonary artery pressures, right? Chamber pressures, then the diameter of the different chambers, then you just this the amount that each cardiac chamber puts out, right? Then ejection fractures, fractions can be measured. Then different diameters of valves can be measured, right? All these functional measurements are done by the cardiologist in the echocardiogram, right? Is that clear? So basically, the patient is completely assessed by the cardiologist. So what you have to understand is, okay, if you ask what they are, remember clinical assessment, which you have to speak about those two, okay? And the instrumental or the cardiology, complete cardiologic assessment, right? Which will include all the tests which I told you, right? So you can measure the pulmonary system, you can measure the heart system, the valves, the chambers, the diameters, the ejection fractions, all these, the pressures inside the chambers, all these are measured by the cardiologist to get a good assessment as to what is happening, right? ECGs, you can look at the arrhythmias or different patterns, right? So these are the ones that are measured. Now, what you have to remember is, if a patient with aortic stenosis, right, is asymptomatic, only mildly symptomatic, the chances of this woman going into heart failure during pregnancy is very small, maybe about 10%, 1 in 10, not much. Okay, so you can tell them, okay, the chance of you going into heart failure is not much. However, you will be monitored, right? If the patient is symptomatic, right, and already having problems, right, and then of course the chance of the woman going into heart failure due to aortic stenosis is about 25%, right? So therefore, usually in the preconceptional clinic, these patients will be, the cardiologist will say, okay, before you get pregnant, please get your problem sorted out. Okay, so usually they will advise, don't get pregnant still. But however, for patients with completely asymptomatic patients or maybe mildly symptomatic patients, maybe they will say, look, go ahead with the pregnancy. However, if there's a problem in the middle, we will look after you. Got it? Right. So this is one thing that you need to remember. Now, what about patients having the aortic valve? Then if there's, sometimes there is, instead of 3 cusps, the aortic valve can have 2 cusps, which is called bicuspid, right? These valves can give trouble. And of course, they measure this. And if the diameter is less than 50 millimeters, then these valves can cause trouble and cause stenosis easily. In which case, you might need to, the cardiologist will tell them, okay, there's a possibility that you might require a surgery even before you go, or they might even require, if there is stenosis, they might require a surgeon to dilate it, or they might even advise replacement of this valve, right? So these are the things that they will advise. So this is regarding aortic stenosis, okay? So remember, the cardiologist may advise a valvuloplasty, right, which may be percutaneous, that is it won't be an open heart surgery, it will be a minimal access percutaneous valvulotomy, which will be given to the patient, right? If the heart valves or the aortic valves are very much deformed, if there are congenital defects, and if they might even ask the patient to get the valve repair surgery or valve replacement. Is that clear? Right. So stenosis, normally they do valvuloplasty. Okay. Next, then we have, this is the initial assessment. Then we have patients who are coming with aortic regurgitation. What is aortic regurgitation? the left ventricle pushes the blood out from the aorta, but the blood returns. But remember, in pregnancy, these patients with aortic regurgitation is better off because the systemic pressure resistance has come down, right? The peripheral resistance has come down. So therefore, when the left side of the heart pushes the blood out through the aortic valve, even if there is incompetence of the valve and the blood returns, still because the resistance is low in the system, it goes out. So these patients with aortic regurgitation does not really have big problems in pregnancy, right? So they do well. However, some of these patients may have atrial fibrillation because what happens is the blood keeps returning back to this. So they might have atrial fibrillation. So these are the things that might happen, but usually aortic regurgitation is very well tolerated. However, it's a big problem then, of course, because the the cardiologist, they might recommend surgery, right, for these defective valves, right, or valve replacement prior to a pregnancy. So these are the risks that we need to understand and discuss about what aortic valvular disease. Is that clear, children? Right. Now, these are the maternal risks. And what are the fetal risks? For any heart disease, children, if you are asked what are the fetal risks, they are all general fetal risks, right? Fetal risk are what? There is a possibility of small for gestation latch or growth restriction. With heart failure and problems, we might have preterm labor, right? If the patient goes into heart failure, the baby also can suffer. So usually it is small for gestational age, preterm labor, very, very rarely miscarriage can occur, very rarely. And of course, very rarely infertile death. These are very rare events, but usually the more two important things are what? Preterm labor and small for gestational age. Those are things which you need to remember when you ask, okay, what are the fetal risks? Now, in aortic disease, aortic valvular disease, if the aortic valve, especially the bicuspid valves, or if there's a congenital defect, one of the risks the babies have is they also might have congenital aortic valve disease, right? So this is something that is well remembered, that any patient who is having a congenital, right? The mother, if the mother has a congenital aortic valvular disease, the baby also can have this problem. But maybe about less than 5%, but it's not much, but still there is a possibility. So therefore, in these patients, if they have congenital aortic valvular disease, the baby needs to be monitored very well for heart disease, and especially fetal echo will be done at 22 weeks if this is the case. Is that clear? Right? So these are the fetal risks that you need to understand. And so we have discussed the mechanisms, we have discussed the maternal risk for stenosis and regurgitation, right? And then we have discussed the fetal risk for these, right? And then, of course, we need to advise them on the general things. What are the general things that we need to advise? Of course, if they are overweight, it's better to lose weight, right? If they have other comorbidities, they need to be controlled. Hypertension, hypercholesteremia, thyroid disease, all these will need to be corrected very well before they go. And of course, they need the normal, their normal folic acid supplementation, the dental, because if there are any dental problems, there is a possibility you might have bacterial endocarditis. So these dental problems must be sorted out in the preconceptional period as well, right? So so these are the general things. And so in general, when they come to the preconceptional clinic, you need to understand what the problem is, diagnose, then MDT with the cardiologist, children. Third, you have to talk about the maternal risk for aortic stenosis and aortic regurgitation, which I spoke about. Then you talk about the fetal risk, right? From this valvular diseases. Then general measures to modify or make the outcome better for the mother, like losing weight, right? And modifying all the rest of the diseases, right? They do have them. And these are the general things in the preconception, like correction of anemia is important, right? Correction of hypertension. So these are the general things that we need to do in the preconception. Is that clear? Any questions? Right? So next, now once the patient is pregnant, of course, remember, the surgery might be offered in the preconception period, which we discussed, right? And then once that is sorted, then they can get pregnant and they come to the first trimester booking visit. In the first trimester booking visit, what is very important is to note down if they have symptoms, right? And put them into the NHI or the modified World Health Organization classification and note down all the symptoms they had pre-pregnancy as well. Because this is in the booking visit, we compare that, right? The symptoms that already had, and each visit we have to ask them whether it has changed. So we need to know initially what they had, right? So therefore, careful in the booking visit. If it's a heart patient, you need to record the symptoms that they have, right? And if they don't have symptoms, you say, okay, no, you don't have this. So if when they appear in pregnancy, you know something is going wrong. Is that clear? So it is very important in the first trimester that when they come in for the booking visit, that their symptoms, right, and their status and the functional class, everything is properly recorded. And of course, they will have to be sent to the cardiologist assessment for a complete assessment of their cardiac status in the first trimester, right? The second thing is, of course, remember in their booking visit, all the rest of the comorbidities must be checked for anemia, for features of heart failure, right? For features of atrial fibrillation, right? And so the ECG must be done. So all these must be done to make sure that we have a baseline as to what is happening in the booking visit. Then in the first trimester, what is important is, of course, remember, some of the babies may have congenital heart defects, especially in women who have congenital heart defects or congenital aortic problems. The baby also might be having those problems, plus some other congenital defects as well. So therefore, in the first trimester, it is important that screening needs to be done. So proper dating, of course, in that nuchal translucency, appearance of the nasal bone, and any defects need to be, if they are visible, you need to do a proper fetal anomaly scan or a screening scan in the booking visit. Anomaly means initially what? Remember, as a minimum, the appearance of the nasal bone and the nuchal translucency needs to be assessed, right? Plus, as I told you, all the rest of the initial normal pre-pregnancy first trimester, the screening and everything, plus the patient must be referred to a cardiologist for complete assessment. Is that clear, children? So that is the first trimester. And of course, the patient must be referred to a dentist to check whether there are any problems with the teeth. So a dental, they must be advised to visit the dentist to check that. Plus, of course, the folic acid supplementation needs to be continued during this first trimester. So that is the first trimester. Give me a moment. Sorry. Right. Where were we? TPJ, RK, Alvis, where were we?
We were talking about first trimester. Sir.
First trimester. Okay, fine. So did I? Yeah. So I would have taught you first trimester. Dating is important, right? But because there may be congenital defects, so nuchal translucency, NT, and the appearance of the nasal bone and any large defects is checked out, right? And then the dental appointments need to be arranged, right, for any dental caries and prophylaxis, right? And general all the problems must be checked. What is very important in the booking visit, remember, careful assessment by the cardiologist and careful assessment by the obstetrician about the initial baseline symptoms that they have. Is that clear? Because we compare that as time goes on with what they had initially. Is that clear, children? So that is the most important thing. Then comes what? Each visit, you need to assess them for symptoms of heart failure and atrial fibrillation and any other symptoms that are appearing at that point. So that is the first trimester. Is that clear? Right? So ECG, echo, all those are done in their first visit and they are completely assessed for their cardiac status. Then next thing is they go on to what? The second trimester. Now, second trimester in aortic disease is the time, if necessary, for surgery. Okay, if the surgery could not be done or if the surgery is planned, then second trimester is the time to go ahead with the surgery. And surgery is decided by the cardiologist, and if they think it is necessary, and if the patient becomes more symptomatic, right, and the patient is going to heart failure, right? So therefore, in which case, then surgery will be indicated. And what are the surgeries? These are, you just need to say, these are percutaneous valvulotomies. Okay, so in the second trimester, what they did, the balloon is put in and then the valves are dilated so that the stenosis is reduced. Is that clear? Right. So this is the center. Plus, what are the other things? And now, what we have to remember is one, that the second trimester, we have to also look at the baby. So there, here we are, because aortic problems, remember, if they are congenital, the baby can have congenital problems, right? So what do we look at it? First of all, anomaly scan is important to look at the baby and see whether there are any problems. Second thing is very important for us to look at the baby's heart, and therefore what is arranged is a fetal echocardiogram is arranged, right? Right, I'm muting all, right, okay. So a fetal echocardiogram is arranged somewhere around 22 weeks. And of course, there should be what? Continuous assessment of the cardiac status. Now, in the third trimester, the cardiologist will, second trimester, the cardiologist will decide of the frequency of the visits, right? Usually, they will see these patients 2 to 3 weekly, and sometimes until about 28 weeks. Okay, so every 2 weeks, every 3 weeks, these patients will be seen. The cardiology assessment will be done. The obstetrician will see them, see whether the symptoms are going the same or whether they are developing new symptoms, right? And this assessment will be carried along. So the mother will be monitored and the baby also will be monitored. And what will the baby, after the second trimester, and when going towards the, after about 28 weeks or so, going towards this, then the baby's serial growth scans will have to be started at 28, 32, 36, because remember, with heart disease, there is a possibility that the baby might have small for gestational age or growth problems, right? So therefore, the baby's serial growth scans will have to be started along with the mother's serial echocardiogram for checking for their status. Is that clear? So that is what we normally do in what? In the second trimester. In the second trimester, again, the risk of thromboembolism needs to be assessed, right? So sometimes if the mother's venous thromboembolism risk is high, right, in which case the cardiologist might decide to start on thromboprophylactic therapy, right? So if they are already on it for some reason, of course, this needs to be continued throughout pregnancy. But for sometimes when if the venous thromboembolism risk is high, then medication like low molecular weight heparins may be initiated during pregnancy by the cardiologist in conjunction with the hematologist if necessary, right? So this is something that will happen in the second trimester. Then, so in short, the surgeries can take place in the second trimester, okay, if the cardiologist decide that the patient is symptomatic, right? Then thromboprophylaxis may be initiated. Then the fetal monitoring, fetal this anomaly scans need to be performed, and fetal echo can be performed in the second trimester. And then there'll be more frequent visits, right, to assess the cardiac status of the patient by ECG and echo every 2 weeks or 3 weeks in the second trimester until the third trimester. Is that clear, children? Right. Then we approach the third trimester. Now the third trimester is after 28 weeks, right? Now, if the patient is still not doing well, and the patient is completely symptomatic, right? And if the patient goes into heart failure, none of the things which you are doing, and if percutaneous valvuloplasty is not possible, right? And still the symptom, even if it is done, still the symptoms are in it, then the patient will need surgery, heart surgery. And therefore, the cardiologist normally will tell us, look, please deliver the baby, right? So that we can perform the surgery. You all understand? So this is the time somehow, if the patient does have problems earlier, right? The obstetricians will be requested, they will be asked, okay, can you please deliver the baby because the woman is going to die, and therefore you deliver the baby and look after the baby. We will go along with our plan of having an heart surgery, either for a valve replacement can be done at that point, right? So it has to be a cesarean section, it has to be planned, and then surgery for the mother will be carried out after delivery of the baby, right? So if not, then of course, if percutaneous valvulotomy is possible, right, or plasty is possible, then they will perform that in the third trimester as well, and we try to continue the pregnancy. And from 28 week onwards, remember, the visits are more frequent, usually every week. 28 weeks, 29 weeks, 30 weeks, 31 weeks. You continue to see these women weekly, right? And the cardiologist will also assess these women weekly or 2 weekly to make sure that the woman is not going to into heart failure. So there'll be more frequent visits in the third trimester, right? Right. So then what happens is, remember, if the woman, the baby is on medication, if the woman is on medication, especially beta blockers, right, for their heart disease, there is a higher chance of fetal growth restriction or the small for gestational baby. And therefore, remember, that is one reason why we need to monitor these babies very carefully with serial growth scans and Dopplers to see whether the baby is having small for gestation age, because we need to have a good observation, or we need to observe the baby very carefully for fetal growth restriction in the third trimester. Is that clear, children? Right. So from there onwards, we go to what? For delivery, right? What are the specific things we need to understand about this delivery? What is the best? Vaginal delivery. Okay. Usually if it's spontaneous onset of labor, that is the best, right? And we can use oxytocin in very low dose infusions. We have to be very, very careful of the fluids that we give these patients. So usually we don't just give it into a drip, right? Normally it's better to take infusion pumps to put oxytocin in, and then infuse oxytocin very carefully, because we don't overload this, right? That is number one. Second, if they go into spontaneous labor very well, they need to be monitored in a place where cardiac intensive care is available, right? So therefore, they will have to have a continuous ECG monitoring, right? The monitor and cardiac support, immediate cardiac support if they go into heart failure, right, or arrhythmias, needs to be there. So the delivery needs to be near a cardiac center or a cardiac ICU. Is that clear? For pain relief, it is best if an epidural is set up so that pain will not provocate arrhythmias and problems in the patient. So therefore, epidural is an essential part of managing a patient with cardiac disease in the labor room, right? So fluid management must be very, very strict. That means it has to be very, very controlled so as to not to overload, right? Then analgesia needs to be given preferably by an epidural, right? Oxytocin, if required, needs to be given in infusion pump, so small amounts of fluids will only go in, right? So fluid management is important, and continuous cardiac monitoring is very important. And of course, there needs to be cardiac critical care very much nearby, because and there must be a cardiac team and people we can refer to immediately if the woman is going to have arrhythmias or cardiac failure. Is that clear, children? Cesarean sections also is the same. So if a cesarean section delivery is necessary, and especially if the woman is in heart failure and is in arrhythmias, of course, she needs to be stabilized, and the delivery is going to be by cesarean section, because we cannot allow a vaginal delivery because she will die otherwise. And therefore, it needs to have an input of all the people: anesthetists, intensivists, cardiologists, obstetrician, and the patient is managed in a multidisciplinary environment with complete cardiac ICU support for delivery, right? And then a cesarean section is performed. And for thrombo, there has to be prevention of postpartum hemorrhage for even vaginal deliveries or cesarean sections. Normally, boluses and ergometrin are avoided, right? So oxytocin can be given in very small infusions, right? If necessary, that is usually best for postpartum hemorrhage prophylaxis. And usually we try to avoid ergometrin or prostaglandins for the prevention of postpartum hemorrhage, right? One of the ways which we can go around it, if there is postpartum hemorrhage in a cesarean section delivery, we can place buttress sutures, right? Especially compression sutures to prevent postpartum hemorrhage, than to use different types of medication that might aggravate the heart disease, right? So these are things that you need to know about the delivery part of them. To summarize, remember, careful monitoring of the mother, continuous ECG monitoring, cardiac support, cardiac ICU, analgesia for epidural analgesia for maker, judicious use of oxytocin, no boluses, no prostaglandin. If cesarean section, the whole team must be there. Then compression sutures can be used to prevent postpartum hemorrhage if necessary, right? And that is how labor needs to be managed, right? Vaginal delivery is the best, spontaneous onset is the best, right? But induction, if necessary, only very small amounts of oxytocin by a syringe pump must be taken, right? And of course, the baby needs to be monitored throughout the delivery stage as well. Is that clear, children? So these are the things. And thromboprophylaxis, of course, stockings needs to be in place, right? And thromboprophylaxis is very important, but you have to stop it during a cesarean section, right? You cannot be giving low molecular weight heparins or heparin infusions during delivery. So you have to restart it later in the postpartum period. So once these women are delivered in the postpartum period, what is very important is ICU care. In the first 24 to 48 hours, these women need to be in a cardiac ICU, right? That is after delivery. Why? Because they can go into heart failure, because the volumes, because the baby's circulation is gone now, and there is auto transfusion into the maternal circulation. So the mother will need to handle more amount of fluid, and therefore they can go into heart failure very easily. They can go to arrhythmias very easily, right? So therefore, the first 24 to 48 hours, the woman must be monitored in a cardiac ICU to make sure that she doesn't have these problems, right? So that is number one. Next to, of course, we have to what? We have to, or any kind of medication is all right after delivery, right? So usually they won't interfere with the breastfeeding. So AC inhibitors, all these, if necessary, can be used after delivery, right? Next is what is this? If the patient is on anticoagulation, they can be started on anticoagulation therapy, sometimes 48 hours later after delivery, right? Sometimes they're absolutely necessary. They may be commenced even sooner, 6 hours later, even after the epidural has been taken out. But usually it starts about 1 or 2 days later, right? So, but that can be decided by the hematologist. So, restarting of thromboprophylaxis medication is initiated in the postpartum period. Okay. And then finally, once all the breastfeeding is not contraindicated, no problem, they can breastfeed. And finally, we need to speak to them about contraception. Contraception, of course, the best type of contraception is long-acting type of contraception. Especially, they can have Mirena or levonorgestrel releasing intrauterine system is very good, right? Those can be used. Jadale can be used, right? And these other things that we advise them to. Even if there is no problem with infective endocarditis, because that is extremely rare, in which case, of course, you can use even a copper IUCD. But the best that is promoted now is the levonorgestrel releasing intrauterine system as the method of choice, if necessary, for these women to have contraception. Of course, if they want to go for permanent sterilization, then it's a different method. They can undergo that with the cardiologist and the anesthetist and support, but which is later. But usually, long-acting levonorgestrel releasing hormone systems are good for these patients. And then they will be referred to again the cardiology clinic later on after 6 weeks, then if necessary for surgery and for further management, right? So this I have taken you through, children, what? The obstetric cycle as to how we manage what? Aortic problems. Is that clear? Right? So this is generally everything, children, that you need to know about these diseases. Correct? Okay? Right. Okay. Now give me 5 minutes. I need to do the things, right? Then I'll get back to you. Just wait online, okay? Okay. So now the next part is we have to talk about very briefly patients who are having mitral valvular problems. Okay, so we have finished with aortic, right? And then we are going to talk about mitral valvular disease. Now the mitral valve is something that is between what? The left atrium and the left ventricle, right? So what are the two things that can happen to this? It can have stenosis and it can have regurgitation, right? So what are the problems initially when they come? Because what is very important is how narrow this valve is during the diameter, not diameter, the area of the valve is very important, and that can be measured by a echocardiogram by the cardiologist. So usually when they come into the preconceptional clinic, right? Of course, as I remember, the MDT and the cardiologic assessment is extremely important. And normally, if the valvular area, right, is less than 1.5 centimeters squared, normally a surgery will be offered in the preconceptional clinic. Definitely, if it is less than 1 centimeter, surgery is definitely indicated before pregnancy. You understand? So 1 centimeter surface area is the cutoff mark. Definitely less than 1.5 centimeters, it is best to do surgery, right? To make sure that they do not go into heart failure. So in these patients, the biggest risk in mitral stenosis is heart failure. And because the blood is not going from the left side of the heart between the from the left atrium to the left ventricle, then these women can have pulmonary hypertension, right? So that is the biggest problem. And therefore, complete cardiac assessment, including pulmonary arterial pressures, right? then all the cardiac assessment needs to be carried out. Right. So what are the problems? Arrhythmias, heart failure, these are the things. Mortality is a possibility about 0 to 3%, right? If there is a severe impairment, especially in NHYA functional class 3 or 4, then if they go into pregnancy, of course, a mortality is possibility. So much so that I'm talking about the preconception clinic. However, if they come pregnant, right, with the valve of less than 1 centimeter diameter, sometimes, and they already have pulmonary hypertension, then of course, these women may be, the cardiologist might request the obstetricians to do a termination of pregnancy because the risk of mortality is very high, 40 to 100%, right? And therefore, they might request the cardiologist to do the obstetrician do a termination based on medical grounds. But that is first trimester. So let's go on to the preconception clinic, right? Preconception clinic, yes, cardiac assessment. The symptoms need to be recorded. The cardiologist will be taken in. So MDT, right? And the maternal risk are heart failure, death, all right? Arrhythmias, everything as we discussed earlier. The fetal risks are the same. What are these fetal risks? Small for gestational age, preterm labor, intrauterine death, right? These are the 3 things that you need to always solve. Miscarriage is very rare, but these are the few things that you need to talk about this. And remember, what is the most important thing, children, is the decision as to whether surgery is indicated prior to going for a surgery. So usually the surgery, if the valvular valve area is less than 1 centimeter, definitely they will offer surgery. Less than 1.5 centimeter also, it's best to offer surgery, right? And then, of course, other risks needs to be modified. If they are obese, they need to lose weight, right? If they are on medication, we need to make sure that the medication is compatible with an ongoing pregnancy or for a pregnancy, right? Then anemia needs to be corrected. Then dental, they need to be referred to the dentist, right, to see whether there is caries. So all these must be modified in the preconception. Is that clear? Right. So next, there is always a possibility that these patients may be on anticoagulation at this point, right? So because of these patients, so therefore, and they may be on various drugs as well, which we need to with the MDT, we need to decide what to do with this patient. First trimester is the same. So assessment of the whatever the symptoms they have, we need to make sure we assess them, because we always will compare what they had when they came to see whether they have new ongoing symptoms, right? So that is the most important. First trimester, these symptoms, plus then if they are already on anticoagulation for these patients, and if they are on warfarin, right, we might need to stop warfarin as we discussed earlier between the 6th and the 12th weeks to avoid warfarin embryo. Okay, so this is what is it. Then initially during the first trimester and in the dating scan, we need to check for nuchal translucency, any congenital anomalies which we can see, and do the proper dating, and of course lay a plan for the next trimesters as to what to do, and they need to be monitored very frequently. The second trimester, remember, always the second trimester is the trimester for surgery, right? So the commonest surgery that is done is called the PTMC, percutaneous, transvenous, mitral, commissurotomy, right? So these are the surgeries that can be done. And usually these surgeries are carried out around 20 weeks if necessary. So these surgeries are carried out if they are in the NHYA class 3 or 4 functional, right? Or if they have severe pulmonary hypertension, if they are decompensating, then these surgeries can be carried out at that. These are minimally invasive surgeries which can be decided at this time. And plus, remember, the baby must be monitored by the fetal echocardiogram can be done, then anomaly scans need to be done, and then continuous during the complete second trimester, there has to be very, very regular visits from the visits to the cardiologist for cardiac assessment as well as the obstetrician, right? So this is what is going to happen in the second trimester of this paper. So basically careful monitoring, then if necessary initiation of thromboprophylaxis, which may be low molecular weight heparins or even maybe warfarin, right? Or warfarin, if it was stopped between 6 and 12 weeks, would have commenced by the second trimester now, and we continue this. And then all these monitoring, very regular monitoring will need to be carried out. Okay. And then these patients come to the third trimester. Now, third trimester, if the patient is deemed compensating, right, and none of the surgeries are not, or not working out, or it's not possible to do, then in the third trimester, normally the cardiologist will request the obstetricians to deliver the baby, and then they will go ahead with the heart surgery to correct the problem to avoid maternal death, right? So this is the time. So they will request for the cesarean section will need to be performed, right? And then once the baby is delivered, then a cardiac surgery is subsequently planned for this patient after delivery, right? So these are the things that will happen. As usual, remember, there'll be more frequent more frequent visits to the cardiologist or assessments every weekly after 28 weeks. And also the fetal growth needs to be checked, because small for gestational age is very common in cardiac disease. So the baby needs to be assessed very carefully to see whether there are any problems with the growth by putting the baby's growth on growth charts. And of course, Dopplers will need to be done for the baby as well if the baby develops small for gestational age, right? So that is what is going to happen up to the third trimester. And then for delivery, what are the special considerations? It's almost the same like other heart disease. Remember, cardiac setup, epidural, right? We need to stop thromboprophylaxis like warfarin. Now, usually warfarin is stopped around 36 weeks, right? And then low molecular weight heparins are introduced, right? And then low molecular weight, then just before delivery, low molecular weights needs to be stopped, because otherwise there'll be a lot of bleeding. So therefore it can be stopped and then restarted after delivery. Then the delivery best is a vaginal delivery possible, right? And the same principles that we discussed in aortic problems is the same principles. Judicious use of oxytocin, very small amount of fluid overload needs to be very, very carefully monitored. So we should not overload them with anything. Medication we give should be given by the infusion pumps, right? There should be a low threshold for instrumental delivery to avoid the mother pushing, right? If cesarean section, it needs to have involved all the intensivists, anesthetists, cardiologists for the cesarean section. Then prostaglandins and large doses of oxytocin, right? Ergometrin is best to avoid. And compression sutures can be used for postpartum hemorrhage if necessary. Especially, remember, these patients may be on medication like bisoprolol, right? These are beta blockers which may have been used, and these also may cause problems with babies, small for gestation. That is why during the second, third trimester, these babies also must be very carefully monitored, because beta blockers can cause small for gestational age, right? So once the delivery is completed, it's the same principle. What you have to understand is the patient must be monitored in a cardiac ICU, right? Because the first 24 to 48 hours is very, very risky. They can have heart failure and arrhythmias, right? Then adequate pain relief must be contributed. Then the analgesia, what is this? Sorry, thromboprophylaxis may be initiated after delivery to prevent thromboembolism. And then if you consider after that, after delivery, breastfeeding is fine. All the medication can be initiated. And then the best forms of contraception is again levonorgestrel releasing intrauterine system. Copper devices, you have to be very careful if there are any infections or problems. Then of course, it's best to avoid intrauterine device. Then you can go with Jadel, right, which can be inserted subcutaneously. Even different kinds of sterilization can be initiated because further pregnancy may be contraindicated for these patients. So breastfeeding is possible, no problem. So therefore, these measures must be taken and then they're handed back to the cardiology clinic for further management, right? So these are the basically things that you need to understand about managing these patients, okay? So I have gone through both, right? And specific problems each of these conditions might, so that covers these two general areas, and that should be enough for you to understand generally how these patients are managed during pregnancy, okay? Right. So next time, children, we will do ischemic heart disease and cardiomyopathies, and that should cover most of the heart disease questions that you are going to get, and for you to understand the general management. Right. I have a question here. Is aspirin probably indicated? Yeah. If the patient is already on aspirin, that's fine. So it doesn't make a huge difference. So aspirin, because the cardiologist might commence aspirin, and therefore there is no problem. You can continue. So aspirin is not a problem. Right? Any questions? Today is a short class because I'm tired. So we will commence. We will do the next class next week. Okay. Okay.
Thank you, sir. Good night.
Okay. Good night.
Thank you, sir. Good night.
Right.